First of all, I'd like to say a very big thank you for the invitation to come and speak. So, unlike many of you in the audience, all I talk about every day is sex. And I've been talking about sex for 27 years. And I have to say, after 27 years, it can get a bit boring. So, although it might seem like a taboo now, the more often, the more you start to ask certain questions, the easier it gets. And I have to tell you that I see many, many patients with a whole range of different conditions. They're not just people with spinal cord injuries. We see people from the MS clinic, the diabetic clinic, women we see from gynecology. So I see a whole range of different people. And I see a whole range of nationalities, a whole range of cultures. And it can be challenging, but it can be good fun, it can be really rewarding. And when you start to talk to men and women and couples about their sexual relationship and you start to help them, it can be incredibly rewarding. And I've certainly got lots of pictures of babies on my walls from couples who are very thankful that they can now have sex. So it's really rewarding. And I would really encourage you all to start to address this issue with your patients, because sex, if it wasn't for sex and sexual intercourse, none of us would be here. Most of us enjoy or will enjoy at some point a sexual relationship, so it's something that unites us as human beings. So I'm going to talk specifically about some of the help we give to women that present in our clinic. So sexual disorders are common with spinal cord injury, which I think we've already established, but there is significant discomfort. But it's not just you who work with spinal injury. It's gynecologists who are uncomfortable. They're uncomfortable in the UK. I mean, in the UK, we've got a very sexualized culture, but we're still in a culture that we find it difficult to talk about ordinary problems for ordinary people. Our doctors find it difficult. I had a meeting last Thursday with a consultant, a gynecologist, who wanted to find out more about sexual problems. He's based in a fertility clinic, but he was interested in helping his patients learn more. I also do training for gynecologists. I mean, gynecology, out of all the medical professions, if they're examining vaginas every day, and they're not asking or thinking about the vagina within a sexual context, I think that's really, really shocking. So what are the common problems we see related to some of the individuals that we see with spinal cord injury or neural injury? Problems with low desire, arousal difficulties, anorgasmia, sexual pain. I thought I'd mention here about sometimes the partner can experience a sexual problem. I had a woman called Fatima that was referred from the spinal clinic. She came, she'd been diagnosed with cauda equina. It was 2 years post-diagnosis, but actually all her sexual sensations had returned and she had fairly normal sexual functioning. Her problem is her husband was experiencing erection problems. So some of you might know you can have erection problems because of organic disease or injury, but you can also develop erection problems because of anxiety and distress. Now, her husband was really anxious about causing her pain because of her cauda equina. So during sexual intimacy, he was getting anxious, and that was having an impact on his erectile function. Now, he worked as a local taxi driver in Nottingham. So myself and Fatima manipulated a situation to get him to come to the clinic because he wasn't keen. He wasn't keen to come into the clinic to talk about his sexual problem for, I presume, a sort of cultural, religious and gender issues. But Fatima and I managed to get him in the clinic, and we managed to get him assessed with regards to his erectile dysfunction, and we managed to get him treated with a PD5 inhibitor. So they both went away being able to enjoy a happy and pleasurable sexual relationship. I just put this slide on because this is a slide that, just to illustrate, if we have negative thoughts, those negative thoughts can lead to feelings of anxiety. If we feel anxious, you get elevated sympathetic tone, increased noradrenaline and adrenaline, and that can have an impact on the contraction of the smooth muscle in the penis. So that is one of the causes of psychogenic That's a physiology behind psychogenic erectile dysfunction. But also, for women, the clitoris is also has erectile tissue. So on the female body, the equivalent to the penis on a female's body is the clitoris. So the clitoris has a clitoral hood, just like the foreskin. You get the glands of the penis, just like you get the glands of the clitoris. Inside the penis, there are 3 arms of spongy tissue. Underneath the labia, there are 3 arms of erectile, 2 arms like a fishbone underneath the labia. So the structures are very similar. So when you have problems with arousal, i.e. erections in men, you can have the same problems through the same process with arousal in women. And that will be problems with arousal because it's erectile tissue in the same way. Problems with pain, of course, if you feel that if something hurts, it's very difficult to stay physiologically or psychologically aroused if you're experiencing pain. So anything we can do to manage pain in practical ways, with or without medication, can be useful. Bladder or bowel concerns. Now, I would say if you're going to be introducing this topic with your patients, I would suspect if you're asking about bladder and bowel, to me that's where you should be asking questions about sexual function. I mean, I don't deal with bowel and bladder issues, but if I see anybody with a spinal cord injury or MS or any other sort of illness that might impact on bladder and bowel function, I will always ask about bowel and bladder function. I had one woman who came to see me, and her main concern was fecal leakage during sexual intimacy. Well, any of us can imagine if that happens, that's embarrassing. It makes us feel uncomfortable. It has an impact on our partner. So I'm usually quite practical. So I was thinking to myself, if we use tampons for a menstrual cycle, surely there must be something for bowel. So I rang up the stoma nurses and said, do you have anything if you have a patient that's worried or about bowel symptoms? She said, yes, we have an anal plug. So she came and dropped them off at the clinic. So I talked to this woman about actually during sexual intimacy, even if she didn't want to use it generally, was to use a small anal plug so she didn't have to worry about fecal leakage. So it was just a practical suggestion really that could make all the difference for that woman. There are physical changes adjusting, which I think we've talked about quite a lot, and changes in relationship dynamics. One of the common behaviours in my experience, and it doesn't matter what the cause of the sexual problem is, but where there's a sexual problem within a relationship or someone is worrying about their sexual function, they'll tend to avoid being sexual. And the problem with avoidance is the longer you avoid because of anxiety or concern, the more that can increase that anxiety. It doesn't decrease it. So when I'm seeing couples in clinic, I always ask them, when was the last time you were sexually intimate? Because if that was 2 weeks ago, 5 weeks ago, 5 months ago, 5 years ago, that might give you an indication of what sort of input that couple or individual needs. If you're a man, I mean, this is the other thing, I get quite passionate about erections, probably shouldn't say that, but So the problem with erections is the longer a man doesn't have an erection, the more impact it will have on the endothelial function of the penis. So if a man doesn't get erections for sex, if he doesn't get morning erections, if he's not getting nighttime erections, that is going to have a negative impact on the endothelial function of the penis. So when you come to treating that man, and we should be treating all men because there are lots and lots of available treatments out there that's already been discussed. If you're treating a man, you need to bear in mind how long he has been without an erection, because the longer it is, the more input it might need in terms of treatment. That might be regular treatment with a high-dose PD5 inhibitor to try and also help restore nighttime erections and morning erections, not just erections for sex. Also, if we use a vacuum device in our clinic, we get them to use a vacuum device daily, sort of bit like a gym for the penis. So we get them to use a vacuum device daily without putting the ring on, where they use it for 10 minutes every day. And what we're trying to do is, one, get the man more comfortable with using the vacuum device so he's not so anxious about it, but also it's about improving his confidence and the endothelial function of the penis. So getting back to avoidance, the sooner a sexual problem is addressed, the less it's likely to impact on the relationship. So if you avoid being sexual, it tends to a reduction in intimacy. It can cause a disconnectedness with that couple, causes arguments, relationship breakdown, which of course that is not what we want for our patients. We want them to have a happy and healthy sexual life within the realms of what's possible. I use sensate focus, which is really, it was introduced in the 70s by Masters and Johnson, and when they introduced sensate focus, it was really a series of exercises to help couples regain sexual pleasure and sexual intimacy. But it was designed really with white middle-class patients in mind who actually could go and lie by the pool or lie on their rug in front of their open fire with no disturb. Well, that's not my patients in Nottingham. My patients in Nottingham, cover the wide socioeconomic background. So if I'm giving suggestions to couples, I need to find out what's appropriate for them and what's possible for them and what did they used to do before they had the diagnosis. Because that gives you an indication about making sure your suggestions are appropriate. If you're living in a home with extended family, if you've got teenagers in the house, if you've got a baby in another room, I can't tell them to spend maybe an hour and a half lying and touching and stroking because there might be babies screaming in the other room. You might have teenagers walking in. So if you are going to make suggestions to couples to spend some time together intimately, make sure it's appropriate for that couple. Ask them what they used to do. So sexuality is complex. The journey in sexual recovery can take time. You can use techniques. Sometimes we use techniques about fantasy. So, you have a culture of meditation in India. Using mindfulness, using meditation is good for managing pain and anxiety. But also when you get relaxed, we often use fantasy, remembering experiences from the past, remembering the sensations you used to feel when you orgasmed, remembering what it felt like to be touched genitally if that's what you enjoyed. And if you keep using meditation and memory and you keep repeating that, for some patients that can have a positive impact because I can feel now if somebody said, what does it feel like if a needle is put in your arm for an injection? I can feel that feeling. I know logically it's not happening, but I can feel that feeling. So sometimes remembering feelings on a regular basis can help with arousal. So this is from the Mayo Clinic. If you want, there's some really good information on this, on the Mayo Clinic, which is based in the USA. There's lots of information there about practical suggestions, medical interventions that you can offer with a variety of patients with sexual dysfunction. But in terms of self-help, what they recommend is mindfulness, acupuncture, yoga. It's just that you need to ensure if you're doing some of these things that, you take into account the injury that you have and making sure you're comfortable and making sure the suggestions are something that person can engage with. And now, of course, we've got meditation apps, which I think is marvelous. So if you can't go to a group or you can't go to a class, you can get meditation apps for your phone. And they're sort of 1 minute, 2 minutes, 5 minutes. And they talk about fitting in those meditation techniques in the in-between moments of your day. So you don't have to spend a long time finding. So the ones I normally suggest are Smiling Mind, Headspace, Calm. They're all meditation apps that you can download onto your phone if you're lucky enough to have one and listen to regularly. So I've read the translation of the Kama Sutra, the English translation, and it's a most amazing book, and especially when you think it was written in the 3rd century AD. I think I don't know whether we were even in the UK at the time, or probably in caves when this was being written. So what I like about the Kama Sutra, they talk about size matters. Now, they're not just talking genitally, but they're talking, if you're going to be talking to patients about positions, look at the people in front of you. If you've got a 6'5" man who weighs 15 stone and you've got a 4'11" woman who weighs 7 stone, if you're going to be suggesting positions, you need to think what positions might be comfortable to that individual because of their physical size. This is in the Kama Sutra. Arousal and orgasm is different for men and women. They knew that then. I mean, we know now we're more complicated, but they knew it through the 3rd century AD. That kissing is important. One person said to me, who worked particularly with men who'd had prostate cancer, who were struggling with erections, that he always said to his patients, you know, you might be struggling to get an erection, but remember, you've got 10 fingers and a tongue. There's other ways of arousing each other by kissing, by touching, by being tactile, using those sensory experiences. Sex toys and vibrators, I know there's a bit, I read online, there's some issue, I think, sometimes in terms of these things, but when you're using something like a vibrator, if you're dealing with someone with a spinal cord injury, you cannot say to them, if you use this, you will restore your function. What you can say is if you use this regularly for a few minutes every day, it might help your ability to get aroused and orgasm. So you have to be realistic to what you're suggesting. We can all learn to be a better lover. You know, it's like dancing, having sex. You have to learn. You have to learn, and you have to learn to make it better. It's not natural like breathing. So setting the scene and sensuality are important. That was also in the Kama Sutra. Taking your time, think about the context. And that motivate, I like that. Women are more complicated, and women's motivation for sex varies. So that, they knew that even then. So I just put this on. There are information that you can see that's about positions, and of course there's 64 positions in the Kama Sutra. I'm not suggesting that you suggest to your patients all of them. I think most of them in the Kama Sutra I couldn't do, but talking about positions is important. And what I sometimes do is when you're talking about different positions, suggest to your patients to try different positions with their clothes on, not to have sex, but to actually rehearse and see what's possible before you want to be intimate and aroused, because then you can find out what's comfortable. If you have issues with lubrication because of arousal, then vaginal moisturizers rehydrate the vagina. So that we use lubricants and moisturizers differently. So vaginal moisturizers rehydrate the vagina, and you use them on a regular basis. You use them unrelated to having sex. It's particularly important with postmenopausal women who can experience problems with vaginal atrophy and vaginal dryness, but also if you have women who are not aroused very easily because of their spinal cord injury, it's making sure that the vagina is well moisturized. Sorry, I've got a very big vagina I'm demonstrating over here. It's not that big, really. Lubricants are actually what you use for penetration. So the lubricant is to help with penetration. If you have a man with whose erection is not as rigid as it once was, using lubrication can make initial penetration easier. Also, for women, it can be more comfortable. You can feel more things with a nice lubricant. We would tend to suggest a silicone or oil-based lubricant because they stay moister for longer. Sometimes with a water-based lubricant, they dry up. But of course, if you're wanting to have a child, then maybe you would just want to use the water-based lubricant. So if you're worried about fertility, probably water-based. But if you're talking about sexual function, sexual pleasure, you'd be thinking about an oil-based or silicone-based lubricant. The only treatment, I've just put the Eros, which is like a clitoral device. That's the clitoris and the penis, they're the equivalent on the body. Now this is like a little clitoral vacuum pump that you would use. It's quite expensive, very limited trials. So, I'm not here recommending it. I'm just telling you aware that it's out there. But what you do is you put the tip over the clitoris and it provides a suction when you turn the machine on, just similar to the vacuum device. And what you're hoping for with regular usage, what you're doing is you're encouraging blood flow to the clitoris that can help some women experience arousal, and it can increase some nerve sensation for some women. But again, we get them to use it for a couple of minutes every day, before, for a few weeks before they know whether it's going to have a positive impact. If people don't have that sort of income, we would suggest a small vibrator, because that's, I don't know, in the UK it's about £20, which, might be available for some people. And the vibrator, we get them to use it in the same way. If you've got loss of sensation, we can't guarantee that it'll give you your sensation back, but if you use something clitorally on a regular basis, that may improve your ability to orgasm. I've used it quite successfully with women who've had breast cancer, who may be on tamoxifen, so they've gone through a medical menopause, and they've got a loss of sensation, so using it regularly can help. So what you can do is start to talk to your patients. The process that Arena went through in terms of sheer embarrassment, and then got to the point where she was happy to come and do this presentation, is the process most of us will go through. You might feel uncomfortable, you might feel outside your comfort zone, but if you're wanting to do the best for your patients, you need to do it. And once you start to talk about addressing some concerns, I promise you it will get easier and easier. And if I was going to introduce it, I would introduce it as a question along with bladder and bowel issues. They're not necessarily, you might introduce it and say, look, these are some of the problems that can occur. Let me know if you need any further help. If you have any issues, invite them back. At least you've put it there that if they do have problems, they know they can come and speak to you. They might not want to address it there and then. You can manage pain and fatigue and anxiety with what we've already talked about, meditation apps. Offer some practical suggestions about positions. You could say, we know things have changed for you. You might need to think, in your intimate relationship with your wife or your husband, you might need to think about different positions. So why not, when you're at home one night and you're just relaxing, just see what's possible. See where you might need some support. See what positions are actually most comfortable for you. You can even do a handout. You could do a leaflet. It just starts that conversation. And also you can get sexual and intimacy apps now. So I might be out of a job soon. So you can get an app that will make suggestions. It's just that you have to look at the app first to make sure the suggestions are appropriate for you or your patients. And you can refer on to specialists and peer educators and peer counsellors. They're going to be a really, really important resource. So I'd just like to finish with that people with spinal cord injury are people first and people with an injury second. And when you are seeing men or women, it's to remember that behind every diagnosis is a person, and behind every person is a story. And we have a responsibility to hear that story. So thank you.